Thank you very much, Dr. Huda, for that kind introduction, and thank you for inviting us to speak at this conference. It's really a pleasure to be here. I was expecting a bit more people in the audience, but maybe because we've got the after-lunch session, hopefully there'll be more people coming in a minute. So, as you all heard from Dr. Ahmed, the Emirates Infectious Disease Society is here. We now have an Emirates Infectious Disease Society, which is great. And our mission is to achieve a United Arab Emirates free of infection, which sounds aspirational, but that's what mission statements are supposed to be. They're supposed to make your stomach ache. And so, but I do feel that we can do this. And I'll ask you to follow us on Twitter. That's our Twitter feed. So if you're not already following us, please make sure you follow us on Twitter. We have a lot of events coming up, and you should be part of it, so please follow us. So I'm going to talk about common infectious disease consults, and I'm going to present a few short cases based on an ID consults, but first from the UK and also from SSMC, but I'm also going to use those cases to highlight some common mistakes in managing infections, and then provide you with some practical tips on management of infections. So it's going to be fast and furious, really nano tips managing infections. I may look a bit young, but these are wise words from somebody who looks young, but I'm not young. Okay. So, let's start with the first case. This is a 72-year-old lady with COPD who is on home nebulizers. So 3 months before you're seeing her, she had been admitted with a fracture of her wrist, and she'd had external fixation. And at that point, there was a discharging sinus, and it grew MRSA. So 3 months before, fixation, sinus grew MRSA. So she's then admitted with a red swollen wrist and breathlessness with type 2 respiratory failure. She has a raised CRP greater than 160, white cell count is 26, and her liver function test shows an obstructive pattern. So this is a chest X-ray. What do you think is going on? Anybody wants to shout? So I think some would say she's got consolidation, probably in the right lower lobe with a pleural effusion. Some would say it's probably pneumonia. So the first pearl is pulmonary dysfunction is quite common in patients with sepsis, and often you would see changes in the lungs on chest X-ray, which are not necessarily the source of infection. So don't jump to blaming the lungs as a cause of pneumonia when you've got somebody with sepsis, and the history doesn't fit with sepsis. This lady's main complaint was her wrist, not her chest. So be careful about that. Her blood cultures grew MRSA and E. coli. So what do you think is the source of infection? You're a bit of a quiet bunch. Source of infection, what do you think? MRSA and E. coli in the blood culture. The wrist. Yeah? The wrist is what we think here. So that brings us to the second pearl, that when you've got somebody with an E. coli in the blood culture, it often comes from below the diaphragm, not above the diaphragm. And often you find people with E. coli bacteremia, people saying it's a pneumonia. Look below the diaphragm. E. coli pneumonia is very rare. It tends to happen in elderly, immunosuppressed, malnourished patients. So when you find E. coli in a blood culture, your focus needs to be below the diaphragm. Urinary tract infection, biliary infection, intra-abdominal infection. Second pearl. So this lady was treated with vancomycin and tazocin empirically. They did an ultrasound scan of her wrist, of her abdomen. It showed acute cholecystitis. And then she had vancomycin for 7 days, and it was stopped. Somebody thought it was a contaminant. Her white cell count was persistently raised, and CRP more than 160. And that's the third point I want to make. Staph aureus bacteremia, you need to know how to manage Staph aureus bacteremia. It is rarely a contaminant in the blood culture. So when you find Staph aureus in the blood culture, you need to take it very, very seriously. And there are evidence-based bundles for managing a patient with Staph aureus bacteremia that improve mortality. And these are the key parts of the bundle. You look for a source of infection, and if you have a focus of infection, try and control the source. For example, an abscess, draining the abscess. Do a cardiac echo to rule out endocarditis. That determines, can change your duration of treatment. And then you do surveillance blood culture every 48 to 72 hours until you get a negative blood culture. And then you treat for at least 14 days from the date of the negative blood culture. And these are bundles that have been shown to make a difference. And if it's MSSA, you use a narrow-spectrum antibiotic like flucloxacillin. And you're treating with vancomycin because it's MRSA, get the drug levels right, dose right. Really important, and that improves outcomes. So she had an ultrasound scan of her wrist. It showed synovial hypertrophy and some echogenic fluid within the wrist. She was treated for septic arthritis with teicoplanin, the same group as vancomycin, as outpatient parenteral antimicrobial therapy, and she did very well. Let's look at this second case. 32-year-old man diagnosed with urethritis, non-specific urethritis, treated 8 years before. He's married and denies any risk factors for STDs. He then turns up with anemia, thrush, and this rash. What's your diagnosis? Diagnosis? I didn't hear. Monkeypox? No, this is a nodular erythematous rash, nodular. So this is a gentleman with Kaposi sarcoma, HIV and Kaposi sarcoma. Remember, birds of the same feathers flock together. So when you find one STD, you need to also look for the others. This person had urethritis 8 years before, was not screened for the others. And so when you find an STD, test for the others. And this patient should have been tested for HIV. Had they been tested for HIV, they would not have presented 8 years after with advanced HIV, very sick, and unfortunately they were treated but passed away. This life could have been saved. So when you find one blood-borne virus, when you find one STD, you must test for the others. You exclude the others. And testing for HIV is not complicated. It is not bad at all. Most patients do not have any fuss. You only need to tell them the benefits of doing the test, how they're going to get the result, and when they'll get the result. And most patients, it is not a problem. It tends to be physicians making it complicated and difficult. You do not need lengthy pre-test counseling anymore for HIV. And if you need a resource, HIV resource for non-HIV physicians, this is a very useful one on this slide. Let's go to the fourth case. 32-year-old Emmanuel worker traveled to Sudan 2 weeks before, presented with fever, lethargy, and dark urine. Treated for chest infection with Augmentin, then ciprofloxacin for a UTI. Seen in a private hospital, and they did a test. What do you think is the diagnosis? So the diagnosis is malaria, malaria, malaria. When you've got a patient that's traveled to a malaria endemic area, your first diagnosis, malaria. You need to rule out malaria. Even if they took prophylaxis, they went to a low-risk area in that country, malaria, malaria, malaria. Mosquitoes don't respect boundaries of low risk and high risk. They may not even have a fever, and they can deteriorate very quickly. So make sure you do a blood film or a rapid diagnostic test for malaria. Let's go to the antibiotic session, which is now about stewardship. At least one third of antibiotics prescribed in hospital are inappropriate. That's been studies done in Europe. In the Middle East, it's probably close to 50% inappropriate use of antibiotics in hospital. And so we've got to be careful and prepare ourselves for the fact that if we continue with inappropriate use of antibiotics, we'll end up not being able to treat patients. And this statement from the Chief Medical Officer, Sir Liam Donaldson in the UK, is really poignant. If every unnecessary antibiotic you prescribe for a patient today, you may be signing a death sentence for a patient in the future. So you maybe think you're saving a life, you may be signing a death sentence for somebody else in the future. So be careful when you're prescribing antibiotics. Make sure it's necessary. And so the next pearl is, not all infections require antibiotics. We've learned that from COVID. Viral infections do not require antibiotics. And source control mycin, that antibiotic, which when you phone us for advice, we often tell you, you don't need an antibiotic, you need source control. That's often what is the only thing that's needed for some infections. A small abscess needs to be drained, often no antibiotics needed. Yeah? And there are some infections which are caused by sticky organisms, like Staph aureus, Candida, Pseudomonas, that if you have a line infection, you must remove the line. If you don't remove the line, the chances of cure are very low and the risk of mortality is higher. So Staph aureus, Pseudomonas, Candida, line must come out if it's a line infection. Remember that. Necrotizing fasciitis, the only antibiotic this person needs is debridement. It's not an antibiotic issue here. You save this person's life, it's debridement. Yeah? And that's exactly what's needed. Let's go to the 10th pearl. It's so easy to prescribe an antibiotic, isn't it? Because we're doctors, we feel we have to get the pen out, we have to prescribe something. They have to come to see us. It's very easy to prescribe, but it's very difficult to stop. And so when you're prescribing an antibiotic, think before you start that antibiotic. Do they really need the antibiotic? And as you get more experience and good physicians, what they do is what we refer to as MICO, masterly inactivity and cat-like observation. If your patient is stable, no evidence of sepsis, no evidence of a deep infection, seated infection, all you need is observation, investigation, observation. You do not need to prescribe something. That urge to prescribe, you need to hold yourself. It's easy to start, but very difficult to stop. And then you need to review the antibiotics at 72 hours. As practice, 72 hours, you should have had cultures back. What you're going to do next. And make that decision. Don't leave it for somebody else. You've got to make that decision. Make the decision. Stop the antibiotics. De-escalate the antibiotics. You've got to make a decision. 72 hours. The 11th pearl. Treat the patient. Treat Mrs. Amna, not E. coli. Your patient is, your patient you're treating, not the bacteria or the culture result. And this is such a common consult. We have cultured this isolate in in a urine culture. The patient is completely well. In a swab, we've grown MRSA. What antibiotic, dear doctor? Treat the patient. How is the patient? The patient is well. It's expected to grow that organism in that sample because of asymptomatic bacteria or because it's colonized, the wound is colonized. You do not need antibiotics. If there's no evidence of a wound infection, it's wound dressing. The patient does not need any antibiotics. And Candida, common also consultation, we have grown Candida in a sputum sample. What antibiotic for that pneumonia? Candida does not cause pneumonia. So you need to examine your patient and see whether they've got thrush. If they have got thrush, treat it. If they haven't got thrush, then they are just colonized with Candida. Don't treat Candida, again, treat the patient. What has the patient got? Have they got thrush? Pearl number 12. Most infections don't need more than 5 to 7 days of antibiotics. Most infections. Unless you've got a deep-seated infection, like meningitis, endocarditis, discitis, and source control will also help you shorten the duration of antibiotics. Hence why we always talk about source control. So remember that. Pneumonia, 5 days of antibiotics is enough for the majority of patients with pneumonia. You do not need more. And the choice of antibiotic is not only what is responsible for treatment failure, another common cause of consult. The patient is not getting better. Should I escalate to meropenem? Before you phone, review the patient in detail. Consider the other reasons why this patient is not improving. Maybe it's not infection at all. It's cancer, metastatic cancer, that's causing their fever. Their white cell count is still high because of metastatic cancer. So it may not be infection. And if it is infection, what about the other reasons why they're not getting better? The abscess hasn't been drained. The line which was infected is still in place. Take it out. Control the source. Get the antibiotics right. Have you got the right dose, the right duration, and the right route? Consider these reasons before you make the phone call of, I want to escalate the antibiotics, dear doctor. The number 14, use narrow-spectrum antibiotics. For most of these infections, when they are sensitive, the narrow antibiotic is the most effective antibiotic. Even E. coli are sensitive to amoxicillin. When I give that advice, often the other person on the other side seems to say, "Are you joking?" If it's sensitive, E. coli sensitive to amoxicillin, it works. Use narrow-spectrum antibiotics. Can you bring the slides back? I'm nearly finished. One more slide. What's that? Okay. So narrow-spectrum antibiotics really are most effective for a lot of infections. MSSA infections, flucloxacillin is the best antibiotic. Strep pneumonia sensitive to ampicillin, ampicillin is the best. You do not need augmentin. Group A strep, always sensitive to penicillin. Penicillin is the right antibiotic. Pearl number 15, you do not need to give IV antibiotics for these antibiotics. They are just as good by mouth as they are IV. So if you're giving somebody a quinolone like ciprofloxacin, they can swallow and absorb, it's just as good orally. It's 10 times more cheap. Use it orally. Clarithromycin, clindamycin, linezolid, metronidazole, same thing. It's just as good orally as it is IV. And these are some references for you, which I will share. And I will not stop with sharing this book, which is one of my missions, which is to make sure that everybody learns the skill of turning a major struggle in life, professional or personal, into success. This is storytelling, a story of how we improve sepsis management in the UK and in Africa after a patient safety event in the UK. And I'll urge you to read the book and learn how to turn struggles into success. Thank you.